Hello, and welcome to the second video in our Australian National Aged Care Classification, or AN-ACC series. In this video, I'll be taking you through the AN-ACC assessments, what the difference is between the AN-ACC assessments and the assessments you use for the purposes of planning care and services. We will also look at how we determine when to request a reclassification assessment and what considerations we should take into account during the admissions process. Let's start with the AN-ACC assessments. The AN-ACC assessment tool consists of 13 assessment sections that include the assessment details of each consumer, technical nursing requirements, the resource utilisation groups activities of daily living instrument, also known as the RUG-ADL, the Australian Modified Karnofsky Performance Status, also known as the AKPS, and the palliative care details section, along with the palliative care phase and palliative care malignancy assessment. It also includes the frailty assessment that looks at falls and weight loss considerations, the Rockwood Frailty Clinical Scale, the Braden Scale for predicting pressure sore risk, and the De Morton Mobility Index, also known as the DEMI. The Australian Functional Measure, also known as the AFM, and the Behaviour Resource Utilisation Assessment, or BREUA. These assessments are completed by an independent workforce known as AN-ACC assessors. The assessment teams are made up of registered nurses, physiotherapists or occupational therapists and have had at least 5 years' experience in caring for older people. When they undertake the AN-ACC assessment, the assessors use a capabilities approach to determine the functional care needs of each consumer. So, what is a capabilities approach? This just means that they are looking at what a consumer can do rather than looking at the assessed needs of a consumer and determining suitable interventions to minimise risk, as we did under previous funding models. The assessors also take into account the functional consequences of health conditions and the effects some of these illnesses, such as pain, cognitive impairment, and mental health, may have on staff time when delivering care and services. For example, a consumer may have a physical capability to shower independently. However, if the consumer no longer had the planning skills required to shower due to a cognitive impairment, the assessor would determine that the consumer is not independent and requires assistance from staff. However, there is an exception to this approach when it comes to behavioural care needs of a consumer. When a consumer's behavioural care needs are assessed, the AN-ACC assessors take a do-do approach as opposed to what they are capable of doing. For example, there may be evidence that a consumer becomes physically aggressive in response to certain situations or certain triggers. The behavioural tool then records the monitoring and supervision required by staff to care for the consumer in order to reduce the occurrence of these behaviours. So, how do assessors determine assessment outcomes? To determine assessment outcomes, the AN-ACC assessors are required to use a high degree of professional judgment, and they consider variances in a consumer's functional abilities and behavioural episodes over a 24-hour period, which is why it's so important for us to continue to accurately document the care needs of our consumers. Sometimes our care management systems contain conflicting information about a consumer. In these cases, the AN-ACC assessors are required to make a clinical judgment using their clinical reasoning skills to determine a consumer's capabilities. Keep in mind that the AN-ACC assessors are required to undertake these assessments within an hour time frame. So in order to get the most accurate AN-ACC class outcomes, it is important that our clinical documentation, such as progress notes, assessments and care plans, are consistent with each consumer's current needs. In addition, they may also observe a consumer and may ask them to perform simple tasks in order to assess their capabilities. The assessors may interview both staff and consumers. It is important that you feel comfortable and are familiar with the consumer's current care plan. If you don't feel comfortable or if you're unfamiliar with the consumer's care plan, tell the assessor and help them locate another staff member who can help them with their inquiries. Now, let's look at what the differences are between AN-ACC assessments and care planning. For over a decade, our approach to completing assessments and care plans has been prescriptive and often related to funding outcomes. Despite our best efforts to merge both person-centred care and optimisation of revenue, our assessments and care plans have always been underpinned by our funding model and the need to improve incoming revenue. So what's changed? The Department of Health and Aged Care have clearly communicated the AN-ACC funding model would remove the documentation burden from providers in regards to completing assessments and care plans for the purposes of determining funding outcomes. Under the quality standards, we need to understand not only a consumer's functional capabilities, but also their needs, goals and preferences. Whereas the AN-ACC assessment tools were brought together to determine the cost of care delivery, and therefore may not be fit for the purposes of developing individualised, person-centred care and services plans. In order for us to develop a comprehensive care plan, we require comprehensive clinical assessment tools to enable us to truly understand each individual consumer and how they would like us to provide care and services to them. When we look at the suite of assessments used for the purposes of determining funding under AN-ACC, we can see these assessment tools provide a measure of functional capability. However, they lack the ability to capture each individual's needs, goals and preferences. As part of the care and services planning approach, we also need to identify risk and determine if a consumer would like to take part in risk-taking activities. It's important that we continue to capture this information so that we can continue to provide care that is tailored to meet the needs of each consumer. By separating the funding-related assessments from the comprehensive assessments used for planning care, we are empowered to focus on truly understanding each consumer at an individual level, rather than grouping each consumer into a funding outcome and delivering prescribed services that fit into their assessed level of care. By having an independent AN-ACC assessor undertake the assessments directly related to AN-ACC class outcomes, we minimise the likelihood of prescribed care based on funding and can focus on driving a culture shift in our approach to planned care and services, allowing us to better meet the requirements of the quality standards. Each provider will have a varying approach to how they determine what works within their clinical framework. Some homes may choose to integrate some or all of the AN-ACC assessments into their clinical frameworks. However, it's important to ensure that we continue to capture the underlying information which assists us in providing person-centred care. Next, let's look at the importance of capturing accurate information within our clinical documentation so that we can identify when our consumers may be eligible for a change in their allocated AN-ACC class. The AN-ACC funding model allows providers to request a reassessment of a consumer's class allocation when there has been a change in circumstances which affects the consumer's cognitive ability, whether or not they have compounding factors, changes in their physical function or mobility status, and if their pressure score risk changes. So, what should we be monitoring in order to identify these triggers and determine if a request for reassessment should be submitted? The top 3 things to monitor are mobility, cognitive function, and compounding factors. Let's start with changes in mobility. AN-ACC is underpinned by the consumer's capability to mobilise, as this affects their ability to function. Any significant changes to a consumer's mobility, such as going from independent to physical assistance, should trigger you to undertake an AN-ACC review. You may also consider monitoring your falls and incident reports, as these provide sound and timely insight into changes occurring with consumers. Next, let's look at changes in cognitive function. Providers should be routinely monitoring each consumer's cognitive function as part of their assessment and care planning process. Sometimes changes are easy to identify, particularly when they are significant and over a short period of time. However, sometimes slow and gradual changes are more challenging to recognise. It's important each consumer has a cognitive skills assessment completed as a baseline upon entering your home, and that each consumer is regularly assessed for changes and that they are monitored, tracked and catered for in how you deliver care. Significant changes to a consumer's cognitive ability should trigger you to review your consumer holistically to determine suitability for an AN-ACC reassessment. And finally, compounding factors. Compounding factors are assigned through an algorithm, which is triggered by the data inputs into various combinations of the AN-ACC assessments. However, the most commonly applied compounding factors are daily injections, unplanned weight loss, where a consumer has lost more than 10% of their body weight, and of course, behavioural disruptiveness. Each home will have a different system and process for identifying where changes occur. Have a think about how you can identify changes in compounding factors at your home. Next, let's look at the admissions process. Depending on the circumstances of each new admission, the initial AN-ACC assessment for funding and classification purposes may be completed prior to entry into the home. These assessments could be completed in a health facility or in the person's home, or within the first 4 weeks after a consumer has entered into care. The AN-ACC tool was designed to ensure there are no incentives for preferential consumer selection based on allocated funding. So when an AN-ACC assessment for permanent care has been undertaken prior to entry, the home will not be advised of the consumer's AN-ACC class allocation. You will, however, continue to receive the relevant documentation, including referral information from the aged care assessment team. As part of your admissions strategy, you should consider undertaking some of the core AN-ACC assessments, such as the DEMI, AFM, Braden, and utilising the ACAD assessment to determine if the consumer has any compounding factors, so that you can estimate which AN-ACC class the consumer would achieve prior to entry. Remember, assessment for care planning purposes should continue as usual. It is a requirement under the quality standards, and there is a one-off adjustment payment in recognition of the additional time and resources it takes to undertake these assessments when somebody initially enters into residential care. Thank you for joining me today. I hope you have been able to take away some key learnings on the AN-ACC assessment tool.